Good afternoon for those of you on the East Coast, and good morning for those of you out west. And I want to thank Gail for doing a great job framing the challenges with adolescent sexual health care and explaining why it matters. So in the next 20 to 25 minutes, I'll talk about what clinicians can do with help from health plans or local health departments to provide quality, confidential care to meet this challenge. So first and foremost, when a clinician first sees an adolescent patient, of course it's important to assess the patient's developmental level because often the cognitive and physical development are not in sync. Given the scope of health issues that clinicians address in an adolescent healthcare visit, we must address confidentiality. I actually think the best approach to confidentiality in adolescent healthcare is actually full disclosure. And what I mean by that is fully explaining to the patient and the accompanying adult up front in the office about the confidentiality policy and what to expect during the visit in terms of the parent or guardian leaving the exam room for part of the visit to provide some private time for the clinician and the adolescent patient. I point out that in just a few years, the adolescent patient will be a legal adult and need to have the skills to effectively communicate with his or her own healthcare provider. And this visit will provide the teen with some practice talking with their healthcare provider and communicating their needs and asking questions on their own. I point out that the parent or guardian will just be around the corner, and if there's a problem, we can bring them back in the loop. It's really a rare event to receive any objections from the accompanying adult using this type of framing. And so when the parent or guardian does leave the room, I explain to the adolescent that everything that he or she tells me is confidential, except if they report an intent to hurt themselves or hurt someone else, then I'd need to get help. I reinforce that I am their doctor and not their parents. And at every adolescent healthcare visit, especially at the preventive healthcare visit, it's very important to do a brief health risk assessment, including asking about sexual behaviors as part of the routine questions. If you feel comfortable and make this just another routine question, the patient will also feel very comfortable. For all adolescent females who report sexual intercourse and males who report sex with other males, it's very important to send a non-invasive specimen for chlamydia and gonorrhea testing, and at the same time obtain a contact information to be able to communicate with a patient confidentially if you have to give a test result. Most teens have a cell phone, so this is usually not a problem. So throughout this talk, I'll be presenting tools that can help providers deliver confidential adolescent sexual health care services. All of these tools are available on public websites, which will be provided at the end of this presentation. So in the next few slides, I'll briefly present some of the tools that we found most useful to help educate about confidentiality and perform the risk assessment screen. So first I'll talk about tools to help inform about confidentiality. So this is an example of a letter to give to families explaining the adolescent services offered at the office, youth risk behavior surveillance data showing the high rates of certain health risk behaviors among adolescents in the particular state, to demonstrate why it's important to provide these services, state laws around confidentiality and consent, and an overview of the office confidentiality policy. We found that when parents are notified and that their children will be receiving confidential services and explain the reasons why before or at the beginning of the visit, they know what to expect and there are no surprises and very little pushback, even if they receive a bill or an explanation of benefits. This is an example of a sign you can put in your office waiting room and exam rooms to inform about the office confidentiality policy. This is an example of the Physicians for Reproductive Health minor access cards that are available free on their website for 13 states that explain the state minor consent and confidentiality laws. In New York State, our American Academy of Pediatrics District 2 New York State collaborated with the New York Civil Liberties Union to develop this Teen Healthcare Bill of Rights, which is meant to inform teens of what healthcare service they have the right to consent, how to ensure confidentiality when possible, and guidance about appropriate health-seeking behaviors. This is a project that could definitely be replicated in other states. So next, I'll show you some tools that have been used to routinely screen adolescent risk behaviors. An easy mnemonic to use and remember is the HEADS assessment that asks about all domains of life. This has further been modified by Clark and Ginsberg to approach screening from a positive rather than a negative, focusing on a patient's strengths and assets, referred to as the SHADES assessment. This is a tool that many pediatricians use in Western New York that was developed with New York State Department of Health support. It's a brief 16-question screening tool at a very low reading level with validated questions that the team can complete in the waiting or triage room or exam room before the provider enters the room. The provider can then skim the results before walking in the exam room to know where they need to focus their questions during the interview and the exam. So this is an example of a page of questions. And you can see that it does include some screening questions about sex. These are just screening questions, and of course the provider would need to confidentiality ask more questions such as the type of sex, oral, vaginal, or anal, the partner's genders, numbers of partners, contraception and STI prevention methods, history of any STI diagnosis or treatment. And again, if you ask these questions as routine, everyone will feel comfortable. An easy way to remember all this is the mnemonic of the 5 Ps, which is asking about partner types and numbers, prevention of pregnancy, protection from STDs, sexual practices, and past history of STDs. So next I'll present some tools that can help providers make some simple changes to their office systems and operations to make their office more teen-friendly and improve confidentiality. So these are some tips that review simple changes that can be made in the office to make the office more teen-friendly and enhance confidentiality. And since many providers really struggle with asking the accompanying adult to leave the exam room, this sheet reviews some strategies to accomplish this task without any trauma drama. The American Academy of Pediatrics promotes their Bright Futures guideline for pediatric health supervision and developing a medical home. They have a section for adolescents with many tools and resources. The National Chlamydia Coalition has published their second edition of Why Screen for Chlamydia, which takes the office through all the steps on how to provide confidential sexual health care, including chlamydia screening. You can see from the table of contents that this monograph covers the full spectrum of chlamydia screening and treatment, taking a sexual history, making systems changes to be able to meet the needs of youth, and resources. So this monograph really walks you through each step of the office visit, from the time the patient enters the office and checks in with a receptionist to the end where the provider may need to give a positive STD test result to the patient and provide expedited partner therapy. So we have all these great tools, and the question is, how can we get them to the frontline provider who are caring for the population at risk for sexually transmitted infections, many of whom are adolescent patients seen in routine care? So now I'll briefly discuss a couple of dissemination strategies that we have used in Western New York. The first strategy I'll discuss is called academic detailing. Some of you have probably heard of this term because it's a strategy to change providers' behavior that's been successfully used for other public health issues, such as changing antibiotic prescribing practices. So academic detailing is academic medical provider educational outreach. The process involves face-to-face education by a trained healthcare professional. Usually it's best if it's a peer, such as a physician to physician, to change provider practices to be consistent with medical evidence to improve patient care. The trainer goes to the provider's office, just like a pharmaceutical rep, and it's based on a pharma's model of a drug rep, known as a drug detailer, that visits the medical office to provide detailed information about their product, along with food and perks like pens or bags or clocks. So we know from pharmaceutical sales that this is a very successful strategy. So public health has tried to replicate this, primarily to change prescribing practices. So we developed a toolkit with many of the resources I just showed you, and we worked with Blue Cross Blue Shield of Western New York to provide us with a list of local providers with the highest volume of adolescent patients. So food is a key component, and we did not have a budget for food, but I admit I made cookies for all of the offices, and the cookies were always such a big hit, and the office were actually very appreciative of a home-baked batch of cookies. So I was able to visit about 25 offices over the course of a year, but I found that even though the providers had the tools and knowledge to provide confidential sexual health care, they just could not get started. So my next question was, how can we actually get the office to make these system changes to practice confidential sexual health care services as part of their regular health care? So we decided to undertake a quality improvement project to enhance chlamydia screening by helping the offices create an adolescent medical home. So you ask, what is an adolescent medical home? Well, the patient-centered medical home is an established concept of an approach to providing comprehensive primary care. The American Academy of Pediatrics developed the medical home model for all children to deliver primary care that is accessible, continuous, comprehensive, family-centered, coordinated, compassionate, and culturally effective. So my question was, could primary care providers develop an adolescent medical home to provide comprehensive and confidential adolescent preventive health care services? So fortunately, we received a National Chlamydia Coalition mini grant to conduct and evaluate this work. Our target population was adolescents presenting for preventive health care visits between the ages of 13 to 21 years. And the project settings were 3 Western New York State private pediatric offices. There was 1 large suburban office with 6 physicians and 3 nurse practitioners, 1 mid-sized suburban rural office with 4 physicians, and 1 small urban office with 2 physicians. Our project partners were Ciccatelli Associates International and the Physicians for Reproductive Health. So the key components of this project were really the tools, most of which I've already presented to you, and the docs really liked the tools. That included a brief confidential patient questionnaire, which the docs love the questionnaire, and a letter to the parents explaining what to expect in the healthcare visit and the office confidentiality policy, and the docs also love the letter. A list of local mental and substance abuse providers because the offices often felt that they needed help knowing where to refer patients who screened positive for mental health and substance abuse risk, and a brochure that listed vetted teen health websites in a brochure form that we encouraged the offices to put information on their websites. So we collected and presented back to the offices their self-reported chlamydia screening rates. And I think the unique component about this project was being able to speak with most of the providers, nurses, and office staff with their chlamydia screening rates in hand and talk about how they could improve their chlamydia screening rates by making simple changes in their patient flow in the office. And the most common easy changes that we ultimately recommended was figuring out where in the visit to screen the teen patients with a health behavior screening questionnaire and asking the nurse or the receptionist to routinely collect urine from the adolescent females before they entered the exam room so that it was available to send when the provider or nurse decided to send a chlamydia test. So I'm going to run through some examples of some tools that I've not already shown. So for this QI project, on the health screening questionnaire, we added a section for providers to self-report their sexual health, contraceptive, mental health, substance abuse, and eating disorder counseling and referral, and most important to the study, documenting if the provider sent a chlamydia test for the patient. As I mentioned, we were able to use these data from each office to demonstrate to the providers how they were doing for universal chlamydia screening their females. Providers always believe that they're doing much better than they actually are, so these self-reported data were very eye-opening for them. Because there's really not enough time to provide comprehensive health counseling, we put together a list of adolescent health information websites that were vetted by a national group of adolescent health experts. Teens like to obtain their information from the internet, so here was an opportunity to give them good sites to go to with good information. Most of these sites also have parent pages, so parents can also surf the web and learn. And so this is a screenshot of the brochure. The patient-centered medical homes usually offer information about health and their offices on their websites, and so we encourage the offices to create an adolescent health website on their office website. Eventually, all the offices did this and were very proud, but I'm going to present a couple of screenshots from one office, Adolescent Healthcare, one office's adolescent health website. So this office put their confidentiality letter on their website, and they also put the list of adolescent health information websites on their webpage so their patients could access it at their leisure. So at the 3-month office visit, we provided the office's feedback on their patient population risk profile, which is based on their patients' questionnaire responses, the provider's sexual health, contraception, counseling, and practices based on their self-reported responses at the end of the patient questionnaire, and their chlamydia screening and HIV testing practices based on their self-reported responses at the end of the patient questionnaires. Given these data, we discussed possible office flow changes to enhance routine chlamydia screening. And they also offered to provide additional adolescent STI and contraceptive management training to all interested staff. At the 6-month office visit, we again provided offices feedback on their patient population risk profile, the provider's sexual health and contraceptive counseling practices, and their chlamydia screening and HIV testing practices. We discussed the successes of their implemented office flow changes and suggested opportunities for improvement. And we also solicited the office's feedback on the project. So now I will talk about what happened. So this slide shows the results of the proportion of sexually experienced adolescent females presenting for a well child care visit who were chlamydia tested at week 10 in black and then in week 20 in purple of the study. You can see that in all the offices there was some improvement, but they were all still far from universal screening. But there is a happy ending to the end of the story. So even though I did not have the resources to continue to formally collect and evaluate data, I did informally meet with the offices to learn about their next steps. So the small urban office was actually very surprised that they were not doing better. To fix this, they decided to conduct their own office QI project to improve their female chlamydia screening. The large suburban office decided that it was too difficult to get all their providers on the same page with this initiative. So they decided to make a systems change where the nurses were instructed to collect a urine specimen on every female 15 years and older and then send the urine for chlamydia testing if the patient indicated she had sexual intercourse on her questionnaire. So this actually became a nursing triage task with standing orders. And then the mid-sized suburban rural office thought that they were doing a great job just by completing the questionnaires on all their adolescent patients, and they did not feel that it was the pediatrician's responsibility to send an STI test. Also, their office was set up was a bit awkward, where the only patient toilet was in the back of the waiting room. And if they wanted a urine specimen after they read the questionnaire, they'd have to send the patient back out to the waiting room in front of everyone else in the waiting room, including the parent, to collect the specimen, which was awkward and disrupted the patient flow. So I pointed out to them that all the other offices in the study were all routinely sending chlamydia tests and were very happy about it, and had not encountered any angry parents, which is, I think, is what they were really afraid of. I also fed them some peer pressure, telling them that your office is the only office that is not sending the chlamydia test routinely. And also, the docs in this practice were very active in our local American Academy of Pediatric chapter, and I pointed out to them that chlamydia testing was actually an American Academy of Pediatric recommendation. So I think they ended up feeling peer pressure, and they made the same systems changes as a large suburban office where the receptionist gave every female patient a urine specimen collection cup at registration for a well child care visit, and the nurse ordered the chlamydia test for all the females who indicated on the questionnaire that they were sexually active. So I just want to point out these are some websites where you can find the resources that I just presented. And so in summary, looking at the big pictures, tools and resources are available out there to help providers deliver confidential sexual health care. It's important to disclose office confidentiality policy and expectations for the visit up front. Successful dissemination strategies include academic detailing and QI projects, and health plans can really play a role in helping offices to make systems changes to improve the delivery of confidential adolescent sexual health care.